Hello, my name is Sonia Mustrick. I am a master's in social work student who is a clinical intern at my field placement called Directions for Youth and Families, or DFYF. I wanted to give special thanks and acknowledgement to C.R. Williams, my clinical supervisor, for providing me this opportunity to intern at this agency, and our professor, Jerry Bean. First, I thought I'd share a related statistic. Did you know that cognitive behavioral therapy, according to Journal of Social Work Values and Ethics, is used by 67% of clinical social workers. Therefore, the use of CBT has tripled since it first sprang up in the 1980s. However, despite its robust ubiquity, more research can be done to assess the specificity of the impact on a target population, which in my evaluation project is on adolescents with depression. Now, Directions for Youth and Families has roots dating back to 1899. It has always has the focus of working with youth and families, hence the name, especially those who are more low income and cannot afford services. And as since the history, it has impacted 8,500 youth. It began with a charity that started back in 1899 and then got renamed to the Crittenton Family Services in the next few years. After undergoing a lot of counseling and intervention, it's really grown. The two additional nonprofits, Juvenile Probation Council and Friends in Action, later then created Directions for Youth and finalized its name in 1983 and became a highly effective organization that provided innovative, culturally sensitive and effective counseling programming to the Franklin County community. Now, there are three primary locations. There is the main office. This is where I have my weekly supervisions and also where I have met with my client for the evaluation project on a 6-month basis. There's another location called the Ohio Avenue Youth Center, which has many programs to help with early childhood education and offer family support services. And then lastly, the third is the Crittenton Center. This began after the agency and the CEO fundraised $9.8 million, which opened the doors to help like 400 youth and 1,000 more families. Now this 20,000 plus square foot social service center, along with all these other centers, work together to address food insecurity, medical services, housing stability, safety, workforce development, senior services, community social sports, and more. I will now go in more depth about the services that DFYF provides. There's three primary hubs. First is the counseling services, which its objective is to address a range of issues, including school concerns, sexual abuse, mental health issues, family conflict, and more. Early childhood has two main programs, the Ready, Set, Grow and the Early Head Start. They both help the kids in kindergarten readiness and works directly with children and parents to enhance learning, and especially if some of the kids need child development skills, as well as prenatal and early childhood support. The last program, After School, is there to provide homework help, recreation, creative arts programming. Both of these, all of these domains are in each of those locations I mentioned earlier. Let's go into the problem. I assessed James, a 13-year adolescent who was diagnosed with depressive mood disorder and trauma. He had exhibited symptoms that led his family to send him to our agency. The context of which I am meeting with him is at the main office, and it's one-on-one, and it's typically an hour-long session on the basis of 6 months. I chose this problem because, as according to the Depression Anxiety 2021, 350 million people globally are affected by depression, and that increases gradually as a child goes into their adolescent years. So going back to that statistic I shared earlier, that is why I decided to incorporate CBT to help address these issues. So what were my desired outcomes? I wanted to do general improvement in these different functioning and emotions, supports a lot of the feelings, struggles that the client has. According to BMC Psychiatry and Journal of General and Internal Medicine, having some form of measurement and assessment for patients throughout treatment is helpful to measure progress and reaching desired goals that focus on the affective, cognitive, somatic domains of major depressive disorders. I will go into depth later, but I used something called individual service plans or ISP scales. And when looking at James' score the first time, which is out of total of 30, the higher the better. He scored 12 out of 30, which is very low. And so the goal from after undergoing intervention of CBT, he would reach to a place of a score of 20 plus or higher. Now we'll go into my evaluation questions. These questions are what helped me to guide the research when determining the effectiveness of the intervention. As you can see, the primary question is in regards of the impact of CBT on adolescent, like James, using CBT when treating major depressive disorder. The rest of these questions are more like guiding questions to help go in more depth of that research. So why CBT? Like I said, majority of social workers use this. According to Early Intervention Psychiatry and Journal of Affective Disorders, CBT is a psychoeducation approach that helps clients in numerous ways, but is also considered a evidence-based practice. And as I've listed here, there is demonstrating improvements in various areas like the self-image of the client and what motivates the client, different thought processes, as well as helping the client get to a point where they're not experiencing those symptoms of depression through undergoing CBT. I did make a logic model to kind of help condense this aspect of how CBT helps in helping adolescents. So I have the first part in the yellow is what is in the inputs. That's what is getting contributed into Jane's client, improvements. And then in the green is the activities that are done related to CBT, as well as the products or what the results should look like. And then the red, the short, medium, and long-term goals that we hope to see in James. I also created a PICO statement. This is just on top of my logic model, was a summarizing point of my evaluation project, which first is client problem depression, second, intervention CBT, third, this was single case, so no comparison, and fourth, outcome resulting in decreased depression symptoms. So what is the measured outcomes that the ISP scales? The ISP scale has 6 or 7 core subgroups. First is the mental health, which assesses frequency and severity of mental health concerns and how it impacts daily functioning. Second, attachments, which evaluate relational security and connection with caregivers and the client. Third, self-regulation helps to measure the client's ability to identify, manage, or express emotions appropriately to stress or triggers. Fourth, their competency or trauma experience, essentially how the client emotionally processes trauma and how adaptive they are. Fifth is school functioning, just the client's performance in educational settings. And then 6, safety concerns, measuring risk factors. Now, there was a 7th subgroup, but it was added on to the ISP scale after I had started James. So I actually do not have a pre-test of this subgroup, which is the pro-social involvement, assessing positive social, recreational, community activities of the client. Now we'll go into the evaluation design. This is a quasi-experimental single group pre-test, post-test. It is tracking one subject for the project, the main baseline level before pre-test, presence of an intervention, and then the post-test is like after the CBT was implemented. which why I chose the ISP scales is because there's a pre and a post the ISP admit scales and then the discharge scales. One provides structured standardized ratings of functioning across multiple domains, as you saw in the previous slide. It also helps to measure changes qualitatively attributable to the 6 months of CBT, and there's observable and measurable outcomes. Second, it's a familiar metric in the agency and is already considered an ethical practice and form of assessment. Third, since there's only one client, James is the evaluation. He is his own control group. So any baseline differences like personality, trauma history, they're constant. And fourth, since this is a scale rating yields numeric data and with the domain breakdowns providing qualitative and quantitative insights into the treatment progress. So just a summary, this design type is quasi-experiment. I'll use the ISP admit as pretest, ISP discharge scale as a post-test. And these are a form of measurement. It's rational, is that it's feasible, ethical, practical, with valid measures. It's part of its strengths. Now we'll go in depth about the limitations and threats of internal validity. So internal validity refers to how confidently you can say that the changes in the client scores were caused by CBT intervention itself rather than something else. One limitation would be the kid himself. What was his household dynamic, the trauma, maybe some genetics, or just resources the school had could impact the client, even their own maturity. The kid may have come into the agency with already skills he learned before, maybe all things that came natural to him and he was able to understand things, or someone may need more maturity when it comes to engaging and understanding those skills. And other limitations too is like there is only one client in this. There's not a way to compare. So it's hard to generalize whether CBT does impact all adolescents in this age range. And so that was some of the threats and limitations. Now we'll go into how the data was collected. It's not really a thorough list. It was through me and the agency being able to host my meetings, and the time frame I did was over 6 months and over the last year. And it was at the office. But what was some issues? First, there was some variability in times. There were some, maybe about 3 weeks, the client was getting sick or family was going on vacation, or even myself being absent for personal reasons, which could have hindered and impacted the data. Especially if times when the client may experience a crisis, there were some sessions that we just couldn't really focus on CBT skills and just needed to work through that crisis in the moment. Like I said, the subscale of the pro-social was added after into the ISP discharge, so that data is not as prevalent and relevant there. Lastly, this is not James giving a self-report. It is myself giving a professional judgment on the progress. So what did this documentation look like? This is a pre-measure. This is like the paper I highlighted, kind of the scores you can see. I know the font's really hard to look at, so it's pretty small. So here's a better a view of it. The ISP score was essentially using a Likert scale, which each domain rated from 1 severe impairment to 5 minimal/no impairment. So the lowest possible total is 6 and the highest is 30. So when James had a summation of 12, this demonstrated a significantly impaired level overall, with several domains, especially self-regulation, showing serious challenges, which is why I mentioned my desired goals. James' score would hopefully get to 20 or higher, which I'll show now the post. Here's the post scales. Like I said, it's also kind of small font. I try to fit it on here. This is the original documentation after James was 6 months later. So I'll give a visual of all those changes. As you recall, the total of 12 indicates that the client was at a very low level in the pre-baseline, but he actually ended up, after the post, reached a score of 24. So you can see in the upper graph, the blue and the orange kind of shows the pre and post changes, which I can go into explaining the observed changes, but of which areas had improvements or which did not or remained stagnant. So here there's the subscales again. The dash means there wasn't any change, and then there's a +1 or +2 overall. James demonstrated improvement in all 5 of the 7 domains, particularly in the competency trauma and school occupational functioning and safety concerns with the positive shifts of +2. This suggests meaningful gains in self-efficacy, emotional safety, daily functioning, aligning with expected benefits of consistent CBT over 6 months. Though the other domains did not demonstrate significant of a change or remain the same, the overall direction was clear improvement. Now looking at the statistical results, this is just primarily descriptive. It could have been a paired statistical test to compare 2 related measurements. But since I'm only having 1 client, this is why it's descriptive, which I will say that this is a large and clinically meaningful improvement across ISP functional domains. The effect size was 1.41, and that suggests the positive change, especially with the score doubling. That is a very profound improvement. That's actually like 100% increase. So implications to all of this, I would say that having a design that has a control group, more clients to determine the data set, I could look into other ways of assessing the data, like maybe utilizing a weekly PHQ-9 scale as part of the assessing the client's progress. I would also want to look at treatment disposition and what are the things I could have done differently, like parent engagement. Having more data where it wasn't would help with knowing where it wasn't working or where it was working. So to conclude, here's a short summary of what I talked about, just provided an overview about various things, and that CBT is impactful for at least this client's depressive disorder symptoms. Thank you for listening, and here are my references